Hello everyone, welcome to my DNP presentation. My name is Courtney Davis and this is my PowerPoint presentation, Implementing Self-Care Management Interventions in Patients with Diabetes. Diabetes affects approximately 32 million of Americans in the United States. Managing diabetes can be a very difficult task. There are a lot of different treatment levels of diabetes. Healthcare providers see it in primary care, which is the main area that diabetes is treated and managed. The other areas include urgent care, acute care, such as the ER, inpatient hospitals, orthos, and ERs around the world. These are all the different levels where diabetes can be managed. Diabetes, a lot of people are aware that diabetes also has a lot of comorbidities and risk factors associated with it, such as heart disease, hypertension, obesity, high cholesterol, and things of that nature. And they all kind of coincide when you get to a certain extent in your disease process, and especially if it goes further and further unmanaged. The purpose of my project is to determine if implementing self-care management interventions in patients with diabetes will aid in decreasing their hemoglobin A1C and or their BMI levels, to aid in control and management of their disease process and hopefully prevent risk factors and associated disease processes with diabetes, uncontrolled diabetes. So a little background about my project and how it is constructed. My project did take place in a rural Midwestern primary care clinic here in the United States. The population is mainly a rural population. It is made up of many different demographics, such as Native Americans, which is very prevalent in the area, as well as Hispanics, Asians, Caucasians, African Americans. We have a little bit of everything. Age ranges, we have a wide variety of age. We have lots of kids running around all the time, all the way up to the elderly populations. We have a local hospital, a couple assisted livings, a nursing home around, things of that nature. My project entailed a retrospective chart review of patient electronic medical records, their charts. Basically, a patient was seen in clinic that is either diagnosed newly or previously with diabetes. They must have had a baseline hemoglobin A1C and BMI level recorded during their office visit in our 1-month intake period. Once they were seen in office, they were given self-care management guidelines pulled from the ADA practice guidelines, which are our basic standards of care based on diabetes. They were given some information and education based on lifestyle management, such as diet, exercise, checking your blood sugars, eating sugar-free foods, exercising routinely like we're recommended to do by the ADA. So they were given this packet of information and this education on self-care management strategies at home and managing your diabetes. After they were given this packet and they were checking out at the end of their appointment, they were queued to the outtake clerk and they were scheduled a 3-month follow-up appointment before leaving the office that day. This was done to help ensure that patients would return for their follow-up appointments, whereas research has shown that a lot of times if you say, here we want you to follow up in 3 months, calling us and make an appointment when it gets closer to that time or anything of this nature, that a lot of patients will not actually pursue that follow-up and comply with that. This way, if you've already got it made for them, they have an appointment card to remind them, they're given a courtesy call to remind them, or a text message or something prior to the day of their appointment. It just increases compliance and therefore would actually increase participants in my study. So that was a good implementation that I thought was necessary, was go ahead and schedule that follow-up appointment before they leave the office that day. So it's already done. They're already expected to come back and return. These patients, once they did return, we did a routine follow-up visit on their diabetes as well as their other associated diseases. We did a repeat height and weight, we did repeat vital signs, and we redid some lab work, including the hemoglobin A1C. So what we did is the data was constructed into a data analysis sheet that was provided to the author, myself, by the office manager of the clinic. The data sample sheet, she was sure to remove any patient identifiers so that there was no risk of confidentiality or breach of HIPAA with any of the participants in the study. Each patient identifiers were removed, and each patient was given a code of a number, a nominal code, so that they were identifiable. Other data that was included in the data analysis sheet and data collection was gender, whether male or female, as well as pre-intervention hemoglobin A1C and BMI levels, as well as post-intervention hemoglobin A1C and BMI levels after their 3-month follow-up of implementing self-care management strategies. Data analysis was then conducted using statistical tests. The statistical test used was the paired t-test. This was determined the most accurate and appropriate test for the study based on the quantitative methods and the use of nominal data, and looking at the correlational relationship between variables whenever self-care management was implemented. After talking with the Maryville statistician as well as the DNP chair, we concluded that the paired t-test was the most appropriate for completing data analysis on my study and my data. So here you can see a couple of graphs. You've got a pie chart and then just a bar graph. Bar graph shows when we started the project, so 11/1/2020, and the details that we studied, so hemoglobin A1C and BMI levels, and then the end date of the research project, which concluded on 4/4/2021. We have our gender breakdown, so we have 41 females and 34 males, which broke down into a total of 54.6% female population and 45.3% male population. We looked at pre and post intervention hemoglobin A1C and pre and post intervention BMI in all patients and participants in the study, including all 75 of those. The results did show that there was a significant correlation in implementing self-care management and the reduction in hemoglobin A1C and BMI levels. Data analysis, the paired t-test was used to compare the pre and post intervention values of both the BMI and the hemoglobin A1C levels. There was a significant difference in the scores of pre and post intervention hemoglobin A1C values, which had a standard deviation of 0.8989, and the pre and post intervention BMI values, which had a standard deviation of 1.1812. The gain was statistically significant with a p-value of 0.0000. The p-value for BMI and hemoglobin A1C were both 0.000, so therefore there was a positive correlation between the relationship between implementing self-care management and the decrease in both hemoglobin A1C and BMI levels. A couple of the issues that were noted, limitations and things in the study, were that we could have delved a little bit deeper, or the author could have delved a little bit deeper into things like race. So yes, we took into account gender, how much hemoglobin A1C and BMI decreased by gender, the difference in breakdown in both male and female population in the study, but I think if the author would have also included breakdowns such as race, I think race would have been, or culture, race would have been a very good variable to also study. A lot of the rural population in this area are Native American, Hispanic, or Caucasian, and a lot of those Native Americans tend to have other comorbidities, especially a high prevalence risk of diabetes, but also associated with heart disease, obesity, and hypertension. So I think it would have been interesting to further study that and the differences and the changes that would have occurred in the hemoglobin A1C and BMI levels of the participants based on their race as well. I think that would have given a little bit more data and a little bit more insight into the changes. Also, I wanted to account for the significance decrease in hemoglobin A1C versus the BMI levels. One factor could have been that all of this study took place during COVID. The current COVID pandemic has placed a lot of limitations on the world. Today, a lot of patients are, their follow-up appointments are being changed to telehealth visits. Telehealth provides some pros and cons in its own. Some things you cannot do in a telehealth visit. You cannot properly assess a patient. There's no real auscultation, percussion. There's no real assessment skills used in a telehealth visit. Also, a lot of those patients, if they're prompted to come in for, a repeat weight, vital signs, they don't have that equipment at home to do that, so they're not going to have that information readily available for you. So if they're going to have to come in after doing a visit over the phone, they're going to be less likely to come in and complete those follow-up requirements such as vital signs, height and weight, lab draws, things like that. And then the COVID pandemic also has placed a pretty significant strain on the population, as well, as many people are more intimidated or are frightened to go out into public, especially to doctor's offices. Usually when people go to the doctor, it's because they're sick. It's not for a routine, a follow-up here, a follow-up there. A lot of times people go just when they are sick. So these patients are more likely to stay home because they don't want to get exposed to those illnesses and viruses that they might be, that they might come across in a doctor's office or waiting room or something like that. So that's another implication that could have caused some skewed data and skewed results in the project. Some of the strengths, though, talk about some strengths of the project instead, and trying to kind of turn it around here. One of the main strengths throughout the research project was the sample size. Although I feel like there could have been several more participants based on the amplitude and frequency and high volume of patients that this clinic sees on a routine basis. But like I said, I think COVID had a lot to do with it. People getting out and about, telehealth visits, not making it to follow-up appointments, and then just getting sick in general and being hospitalized or at home sick, quarantined, and things like that. So the population size, 75 patients, is how many were included in the study. This is an ample sample size, especially for the statistical test that was used in this study. But I would have, the author, I would have liked to seen this much higher. And then, like I said, I wish I would have delved deeper into the racial differences and how self-care implementations affected the differences in the different races as well. Another major strength of the study was using the data analysis and the paired t-test. The results were they did meet the objectives of the study, so therefore it was a successful study. It did meet the hypothesis, and it did show a positive correlation between implementing self-care management and patients with diabetes. The data can be used for future implications. Future diabetic patients in the clinic can be educated with this same education, and these same self-care guidelines and interventions can be used on them as well. So this can help future patients who are diagnosed with diabetes, and it can also help aid in education and just basic reminders even for your staff, I think, if you implement this education into your practice. The information was pulled directly from the American Diabetic Association website from their self-care guidelines, like I said. So it's it's the standards of care for treating patients with diabetes and implementing those self-care management interventions. So it's easy to find the research, it's concrete research, it's evidence-based practice. So therefore it is appropriate to educate your patients and give them these packets and education handouts and these resources. There is a positive relationship between implementing self-care management and the BMI and hemoglobin A1C decrease. However, further research should focus on the different variables like I noticed, such as the age. Age would be one thing. I only looked into the gender, but we could have broke it down into age groups, 18 to 25, 26 to 34 type thing. Geriatric populations, pediatric populations were eliminated because that's just a really different situation when it comes to research. It should also, further research could also include a way to ensure compliance with the treatment plan. However, this is kind of difficult. The interventions that I took in this project to reduce the risk of non-compliance and returning for appointments and implementing the self-care guidelines and things like that, were going ahead to schedule the follow-up appointment before leaving from the first appointment. But things that could have been done would be like weekly phone calls from like the nurse or the case manager at the office to ensure that patients are implementing those self-care guidelines and that they're not having any issues or difficulties or running into obstacles. So ensuring compliance could be any kind of future implication for research. The data and the research that was conducted here and concluded, it can aid in the continued studies of diabetes in Americans and also rural Americans. Although the data in this project do show a positive relationship between the implementation of self-care management and control of diabetes, further research is necessary. The continued development and treatments and control of diabetes will only aid in the continued advances in the diseases and the control and reduction of complications and risk associated with the disease. So it is necessary for us to continue education. Diabetes is has a high prevalence rate in Americans, so it's necessary that research continues on, and proper disease management and treatment, it helps decrease the risk of complications. This can include wounds, amputations, medications, ER visits, hospitalizations, physician visits, labs, infusions, all kinds of things that can really amp up those costs associated with diabetes. Primary care providers must be able to properly diagnose and treat diabetes, so that is another implication for future research. Continuing research into the disease process, the pathophysiology, the treatment plans, how effective our self-care management is in those treatment plans, and reducing risk associated with diabetes and increasing the compliance and the control of and treatment of diabetes is critical for the future of nursing and the future of our American society. Future research on self-care management in patients with diabetes should include further variables such, like I said, as race, age, gender, and presence of comorbidities. Another major factor might be to consider compliance. Like I said, the compliance is a huge factor. This could include provider-driven self-care management courses or programs that have a way of ensuring compliance, so these patients are automatically enrolled. We already have like heart failure programs, we have COPD, respiratory therapy programs, respiratory rehab. Might be something as to go like your primary care clinic implements a diabetic rehab or something like that, where they really work with those diabetic patients on their ensuring a proper diet, a proper lifestyle, smoking cessation, making sure they're doing their exercise every week, and then seeing what barriers that they're meeting and facing and what you can do as their provider to really help them overcome those obstacles and get around those barriers so that they can meet their treatment goals. Here is a list of the resources used to complete my presentation today. I hope that you all enjoyed it, and I hope that maybe you learned something about diabetes, and I hope that you comment with any questions or any concerns, anything that comes to mind. Anything is welcome. Thank you.